We are talking about the embryology of the GIT. So we'll start first with the embryology of the foregut. Remember one test that they brought for me, it was an essay. They just came right about the embryology of the midgut and mention all the congenital abnormalities associated. Okay, so we need to understand the embryology of each part of the GIT, foregut, midgut, and hindgut. So starting with the foregut, you know that the embryo folds. There is cephalocaudal folding and the lateral folding. Cephalocaudal, this is where the embryo is going to fold starting from the head to the tail end. So it folds like that. And then the lateral folding, this is where the sides fold and then they merge. And connection after these two foldings is going to take the endoderm lined yolk sac. The yolk sac basically is going to be engulfed, okay, into the embryo, and that is going to form the primitive gut. That is how you form the gut from that same folding. And two other portions of the endoderm, which are also, uh, of course, these two other portions are also lined by endoderm. You have got the yolk sac and the allantois. Okay, so the allantois, this is at the end. Okay, these will remain inside the outside the embryo, the allantois and the yolk sac itself. In cephalic and caudal parts, the primitive gut will form blind ending tube, which is foregut and hindgut respectively. Blind ending, the meaning of that is that at those two ends, like the structure just was going to vanish like that, it will close up. So midgut is going to remain temporarily connected to the yolk sac by means of the vitrine duct. So this is what happens. You can see this was it here, like somewhere in the third week. The embryo started folding. You can see this is it folding craniocaudally, starting from the head to the tail. That folding is happening. Of course, as that is happening, there's also lateral folding that is happening. And then what happens that what was the yolk sac, part of it is being engulfed inside, being taken inside, and is going inside like that. Can you see? Okay. So the front here is going to form the foregut. The end is going to form the hindgut. The middle form the midgut. Can see that the yolk sac remains outside the embryo, and also at the end the allantois remains outside the embryo, and the midgut is still attached to the yolk sac via what, the vitrine duct. Okay, so the foregut, what are some features that is going to have, or what makes up the foregut? So I've going to have the pharyngeal, this is we're going to have the pharyngeal gut or the pharynx here, which starts from the oropharyngeal membrane where the mouth is supposed to form to the respiratory diverticulum. So there is a diverticulum where the respiratory system is going to be coming from. That is the respiratory diverticulum. Okay, just near the, is in the foregut here. So we are going to have the respiratory diverticulum. And then the remainder of the foregut, apart from the pharyngeal gut, which is caudal to the pharyngeal tube, okay, to 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 the liver outgrowth, where the liver is going to be growing. These two parts will comprise the foregut. So the very beginning is the pharyngeal gut from the oropharyngeal membrane to the respiratory diverticulum. Okay, the pharynx, is going to develop from the arch, from the pharyngeal arches. Already discussed pharyngeal arches. You even discuss it even more in head and neck. next year. And then the mid gut, so all the way from the mouth, when you reach to the duodenum, the second part of the duodenum, that's where the mid gut starts. So the mid gut is curved to the liver bud and extend to the junction of the right two thirds and left third of the transverse colon in the adult. The transverse colon has got the proximal two thirds and the distal one third. The proximal two thirds is part of the midgut. The distal one third, that's if hindgut. And hindgut is from the distal one third of the transverse colon to the cloaca membrane. In this case, this is in children. In adults, it's to the anal canal. So the endoderm is going to form epithelial lining of the digestive tract. Remember, basically the GIT develops from endoderm. So the endoderm is going to form the epithelium, and that will give to rise to specific glands. For example, the cells of the liver, the hepatocyte, and the exocrine and endocrine cells of the pancreas. The stroma connective tissue of the glands, like the stroma, the supporting tissue of those glands that are coming from this same GIT, primitive GIT, is going to be derived from visceral mesoderm. So connective tissue doesn't come from endoderm, it will come from visceral mesoderm, connective tissue of these same glands. Muscles, connective tissue, peritoneal components of the whole of the gut also are derived from visceral mesoderm. Remember, mesoderm is also divided into a lot of layers. Okay, this is visceral mesoderm. So the muscles in the GIT, the smooth muscles that we know of, inner circular, outer longitudinal, and those others come from the visceral mesoderm. So this is the GIT again. You can see the pharyngeal tube starting from the oropharyngeal membrane going all the way to somewhere here. You can see the tracheobronchial diverticulum. This is where the respiratory system will basically get to come from. Okay, and then you have got the continuation, and you can see the bulging stomach there. And then you have got the liver bud there, the pancreas the other side, and then you have got connecting to the yolk sac via the vitelline duct, and the allantois is also in the umbilical cord there. Okay. At the end, you have got the cloaca. At the beginning, you have got the stomodium, that's where the mouth is going to open. At the end, you have got the proctodium, that is where the opening of the anal canal is going to be. And can you see that the cloaca, the distal end starts, the proximal end starts developing into the bladder. This is the bladder that is developing. Okay. So meaning that the same part that was giving as part of the GIT is also giving as part of the urinary system. We have got mesenteries when it comes to talking about the GIT. Mesenteries, these are just uh, folds of peritoneum that suspend the parts of the GIT into the ventral body wall. Okay. Let's say, for example, the intestines just stayed like in the cavity, in the abdominal cavity, they would be folding, isn't it? So they are held to the abdominal wall by mesenteries. And organs which are enclosed by mesenteries are known as intraperitoneal organs. Those without mesenteries are retroperitoneal organs. We also have peritoneal ligaments. These are double layer of peritoneum or mesentery, and they pass from one organ to another. Mesenteries are just ligaments which will provide pathway for vessels, nerves, lymphatics, and from abdominal vessels. If we say ligament, don't think of attaching a bone to a bone. This is a special type of ligament. Okay, these which are found inside the body. So inside them, you are going to have blood vessels, nerves, lymphatic systems. Okay, all those things. So initially, the foregut, the midgut, the hindgut are in broad contact with mesenchyme of the posterior abdominal wall. Okay, so this is basically the mesoderm, the mesodermal tissue of the posterior abdominal wall, they are very much in close contact like that. And in the fifth week, the dorsal mesentery that suspend the mid gut and the major portion of the hind gut is going to form. Okay, is that okay? So you're having the formation of the dorsal mesentery. The dorsal mesentery, what is it doing? It is basically holding the mid gut and the hind gut close so that they don't fall like that. And the dorsal mesentery starts from the lower end of the esophagus to the cloacal region of the hind gut. What does this dorsal mesentery form? It would form the dorsal mesogastrium or greater omentum. You will see this one will be talking about the gross anatomy of the GIT of the abdomen soon. So greater omentum is like an apron-like structure that is in front that will cover the intestines. So it is coming from the dorsal mesentery. Okay, and then the dorsal mesoduodenum also come from the dorsal mesentery, the dorsal mesocolon, and then the mesentery proper. Mesentery proper is going to be holding the jejunum and the ileum. The dorsal mesocolon is basically holding the colon, the large intestines. And then I've got the dorsal mesoduodenum that is holding the duodenum. So these are the mesenteries that come from the dorsal mesentery. So look at this. You have got this posterior here. This was initially the connective tissue, but now it developed into the dorsal mesentery, which had to hold the GIT from the mid gut. Okay, mid gut, and we said we are starting from where? It's basically suspending the mid gut starting from the lower end of the esophagus to the cloaca. You can see from the lower end of the esophagus to the cloaca there. And then it's going to form the part that is connecting. So I've got a dorsomesogastrium. The word meso, just gastrium is meaning stomach. So attaching to the stomach, like holding the stomach to the posterior abdominal, that's dorsomesogastrium. Like for these messengers, you just hear meso, meso, meso. And then there is this part that is holding, it is posterior to the duodenum. That is the dorsomesoduodenum. And then you have got the mesentery proper that is going to hold the jejunum and the ileum. And then you have got the dorsal mesocolon, and the dorsal mesocolon is basically holding the colon, the large intestines. Okay, and can you see that each one of these regions is going to be supplied by specific artery? So as the foregut is developing, with the celiac trunk. In here is called the celiac artery. As the midgut is developing, it is developing with the superior mesenteric artery, and then the hind gut is developing the inferior mesenteric artery. So all the structures that are going to develop from the midgut will be therefore supplied from by the superior mesenteric artery. All the structures coming from the foregut, things like the liver, they are part of the foregut, the stomach, they are part of the foregut. So those are going to be supplied by the celiac trunk. Okay, you can see at the end you're also going to have the umbilical artery that is going into the umbilical cord. So that was the dorsal mesentery. You also have the ventral mesentery, but the ventral mesentery is derived from the septum transversum. Okay, and exists only in the region of the terminal part of the esophagus, the stomach, and the upper part of the duodenum. Ventral mesentery is not extending out all the way up to the cloaca. It's just the terminal part of the esophagus, stomach, and upper part of the duodenum. Growth of the liver into the mesenchyme of the septum transversum divides the ventral mesentery. So the liver actually develops where? In the septum transversum or the ventromesentery, which develops into the ventromesentery. Okay, take note of that. The dorsal mesentery, that should be where the pancreas develops. So the lesser so because of the developing liver, the ventromesentery, which is developing from the septum transversum, is going to be divided into the lesser omentum and the falciform ligament. The lesser omentum is going to extend from the lower portion of the esophagus, stomach, and upper portion of the duodenum. Like you're starting from the esophagus, right? Connecting the esophagus, the stomach, and then covering the duodenum and to the liver. And then the falciform ligament is going to extend from the liver to the ventral body wall. You know the ventral body wall? Just like we have got a posterior wall, like at the back. The intestines are attached to the back. So the liver is also attached to the front. Okay, that's the ventral body wall. So take note of the falciform ligament, very important structure. Okay. So let's start with the esophagus. Esophagus in a 4-week embryo, you are going to have the respiratory diverticulum or the lung bud that is going to appear at the ventral of the foregut at the border with the pharyngeal gut. Okay, pharyngeal gut. No, pharyngeal is just representing the pharynx, isn't it? And then tracheoesophageal septum is going to gradually partition the diverticulum from the dorsal part of the foregut. So we add this diverticulum, the lung bud, in the foregut. But then you are going to have this tracheoesophageal. You know the esophagus and the trachea are separated from each other. But initially these guys were not separated. Like the respiratory system is developing from part of the GIT on those buds. Okay, so we're going to have a tracheoesophageal septum to divide the trachea and the esophagus, and that is going to be able to partition the diverticulum, which is the same lung bud or respiratory diverticulum, from the dorsal part of the foregut. Okay, so in this manner, the foregut divides into ventral portion, the respiratory primordium, and the dorsal portion. Uh, the dorsal portion esophagus. At first, the esophagus is short, but with descent of the heart and lungs, it lengthens rapidly. So this is what we are trying to say. Initially, we only had what? The foregut and a respiratory diverticulum. And then we were forming now the tracheoesophageal septum to separate now these two guys, and then the trachea had to separate. What remains there is going to be the pharynx. Okay. And then at the end of the pharynx, that's where you have got the esophagus. You can see again here the proximal blind end part of the esophagus. So initially the proximal part is blind, like it ends. And then you have got the distal part also that is connected to the tracheoesophagus. So it's still connected to the trachea and by the tracheoesophageal fistula. It will then divide and then communication is going to happen. Okay, communication of esophagus with the trachea is going to happen again. You can see connection gets to happen. That's why when you are eating, the trachea has to close so that food doesn't go there because there's a connection. Okay, so variations of esophageal atresia or tracheoesophageal fistula in order of their frequency of appearance. Sometimes you can have all these problems that you can see here. Sometimes there can be a separation of the esophagus, as you can see here, and that's the majority. Sometimes it can be like this, sometimes like that, sometimes like that, and then sometimes like this. Okay, so those are all congenital problems that can arise. And then the stomach appears as a fusiform dilation of the foregut. in the fourth week. You know the meaning of fusiform, a bit of extended at two ends. But changes are going to happen. Okay, changes are going to happen when rotation begins to happen, because when you're forming the GIT, rotation happens. The stomach, please take note of this. The stomach rotates 90 degrees clockwise. Please take note of the degree and the direction, not anti-clockwise, but clockwise. Okay, and that causes its left side to face anteriorly and its right side to face posteriorly. Hence, left vagus nerve innervates the anterior wall and the right vagus innervates the posterior wall. Take note, right vagus is going to innervate the posterior wall of the stomach, then the left the anterior wall. Because remember, what was left came anteriorly because of this rotation. That's why the left vagus innervates the anterior wall. So initially it was like this, and then a rotation happened, and that was in a clockwise direction. A rotation happens, and then it ended up being like this. You can see the lesser curvature forming here and the greater curvature. Okay, so that is what happens. Any question? Okay. So during the rotation, the original positional posterior wall of the stomach grows faster. What was the posterior wall grow faster than the anterior portion? And that will form the greater curvature. And then what used to be the other portion, the anterior portion, is going to be growing a bit slowly, and that will form the lesser curvature. The cephalic and caudal ends of the stomach originally lie in the midline, like they are the center. The beginning and the end of the stomach, initially they are the center. The anteroposterior axis rotation causes the caudal. Remember the end of the stomach, that's the pyloric part. And that is going to move to the right and upward. That's why the stomach changes a bit like this. Can you see? It tends a bit up. Initially it was on the midline, if you can see B. But then it tends a bit up like that, the pyloric end. And so that pushes the cardiac end to move to the left and slightly down. So the stomach is attached to the dorsal body wall by the dorsal mesogastrium, as we said earlier, and it's also attached to the ventral body wall by the ventral mesogastrium. Its rotation and disproportionate growth will alter the position of these mesenteries. It will change. So rotation about the longitudinal axis is going to pull the dorsal mesogastrium to the left, the one at the back, creating a space behind the stomach which is called the omental bassa or lesser peritoneal sac. I should have put a cadaveric picture because in DRA when you be doing it should be practical too. They can bring that. Okay. So the same rotation that is happening is also going to pull the ventral mesogastrium to the right. Okay, the ventral to the right. So look at this. So the stomach here. You can see how the stomach is connected to the posterior abdominal wall. So this forms the greater omentum. So the greater omentum is going to have two layers. There's a layer that is going down and the layer that is going up. These layers are normally fused. There are actually four different layers. Okay, four different layers, because this layer is going to continue like this. This is one, and then it's going to turn like that. That's going to be two, and then you are going to continue going like that, and then you come back down here. That's the three, and then four. So these are actually four layers for the greater omentum, which are going to be fused. Okay, there's actually a space that can be used to penetrating the back that is known as the omental bassa. Omental bassa. The spleen and the pancreas is going to develop from within the dorsum. Please take note. The ventral mesentery, we had the liver developing there. The dorsal mesentery, specifically dorsal mesogastrium, that's where the spleen and the pancreas will be able to develop. So organs like the pancreas, these guys are initially covered by peritoneum. But then as development goes on, they lose the peritoneum. They become retroperitoneal organs. So because they initially had peritoneum, they are known as secondary retroperitoneal organs. Okay. So you can see here again, this is the stomach. It is attached to the anterior abdominal wall via the ventral mesentery, and that's where the liver develops. And then to the posterior via the dorsal mesentery or the dorsal mesogastrium, that's where the spleen develops, including also this pancreas. So this layer, you can see the liver starts to develop all the more faster, but it still remains attached to the anterior abdominal wall. And that ligament that still attaches it there is known as the falciform ligament. That is the same with in adults, is still there. And then the liver is attached to the stomach. Initially, can you see that it was attached via the ventral mesentery here? So the ventral mesentery was separated actually into to this one in front and this one on the middle here. So the one on the middle here will end up being the lesser omentum, connecting the liver to the stomach. That's a lesser omentum. Okay. And then you have got this one, the linorenal ligament. It's connecting the stomach to the posterior abdominal. And then you have got this space here. This space here, that's known as the omental bursa. So what was the omental bursa, as we said? Because of rotation, the dorsal mesogastrium is pushed to the left, creating a space. Okay, you can see there a space behind. That's omental bursa. So there's actually an opening that opens for us to go to the omental bursa. And you can see again, this is the omental bursa, this space here between the stomach and the dorsal mesogastrium. Okay. And then here is the lesser omentum, the connection between the liver and the stomach. The pancreas is there, is developing in the what? In the dorsal mesogastrium. And it is outside the abdominal wall. So it is a retroperitoneal organ. You can see this is a greater omentum. Greater omentum comes and covers all the intestines. It's even short here. Then you have got the mesentery proper that attaches the jejunum and the ileum to the posterior abdominal wall. Okay. What about the lesser omentum or the falciform ligament? We know that the lesser omentum and the falciform ligament, they come from the ventral mesogastrium, as we already mentioned. So when liver cords grow into the septum, it thins to form peritoneum of the liver, falciform ligament, lesser omentum. Basically the same folds that we're talking about. These same folds were here. Okay, same the ventral mesentery. It actually enters the liver and forms all these layers. Peritoneum of the liver, that surrounding of the liver, the falciform ligament that attaches the liver to the anterior abdominal wall, and the lesser omentum that attaches the liver to the stomach. The free margin of the falciform ligament will contain the left umbilical vein, and the vein is obliterated after birth to form the round ligament of the liver. Please take note, exam questions, huh? Okay. They will ask you what is the remnant, or from where did the ligamentum teres hepatis remain. Now ligamentum teres hepatis, teres just representing round, and there are a lot of things that you hear as teres in the body. Hepatis is different into liver, so round ligament of the liver or ligamentum teres hepatis is actually developing from the left umbilical vein. Please, not just umbilical vein, left umbilical vein. The right limb is going to do something else. The free margin of the lesser omentum connecting the duodenum and the liver contains bile duct, portal vein, and the hepatic artery. That is known as the portal triad. Remember, connecting the liver to the duodenum, hepatoduodenal ligament. So there you are going to have those structures. Okay, from the liver to the duodenum, you're going to have all those, the bile duct, the portal vein, and the hepatic artery. Talked about them in the GIT. This is what you can see here. Here, you're connecting the duodenum just a bit down here to the liver. Okay, so those are the structures you're going to find at this region. So remember we talked about the opening that is left when there is a rotation. So there's actually a window that we can use to go to that foramen. That is known as the oment or the eploic foramen of Winslow. So this space here, the eploic foramen of Winslow, is going to open to the omento bassa. The one that we talked about, the opening that is left a bit posteriorly. Okay. So that is going to connect the omento bassa to the rest of the peritoneal cavity. And then the duodenum, the terminal part of the foregut and the cephalic part of the midgut forms the duodenum. Can you see that the duodenum comes from the foregut and the midgut? The junction of the two parts is directly distal to the origin of the liver bud, just a bit distal. As the stomach rotates, the duodenum takes on the form of a C-shaped loop and rotates to the right. Okay, it rotates to the right. This swings the duodenum from its initial midline position to the right side of the abdominal cavity. Duodenum and the head of the pancreas press against the dorsal board wall. So you can see this was the pancreas developing in the dorsal mesoduodenum, and then after rotation clockwise, look at how it forms. Okay, you can see where it is now, the pancreas. So the right surface of the dorsal mesoduodenum, the right surface, this is the surface that you can see, the right aspect here. Okay, is going to fuse with the adjacent peritoneum. Both layers will then disappear and the duodenum and the head of the pancreas become fixed in retroperitoneal position. Please take note, this is important, alright? This is important. You can see the way these guys are attached like this. The duodenum and also the pancreas. Here is the pancreas and duodenum. Okay. So what will happen is that these structures, when the duodenum is going to be looping, the head of the pancreas and the onset process will end up being enclosed by the duodenum. That's what we are explaining here. So the entire pancreas will obtain a retroperitoneal position. It goes outside the mesentery. It's not covered by peritoneum. The dorsal mesoduodenum disappears entirely except in the region of the pylorus of the stomach, where a small portion of the duodenum retains its mesentery and remains intraperitoneal. Okay, so the stomach remains intraperitoneal because it didn't lose that dorsal mesentery. And during the second month, the lumen of the duodenum is going to be obliterated because like it was closed. The lumen is recanalized. Okay. Since the foregut is supplied by the celiac artery, so you can guess what to supply also the duodenum. So in the foregut, you also have the liver, the gallbladder, and these other structures that are also developing from there. Okay, but let's pause for now just here. We'll get to discuss all those others in the next class for good understanding. All right.